All right, sir. Shall we start, sir?
Yeah. Can I hide this or this will be always there?
As you wish. If it is convenient for you, you can keep it or you can.
No, it's okay. Let it be there.
Okay. All right, sir. We are starting.
Starting the top.
Yes. Hello and
Uh,
welcome to all. This is Ankita, the assigned moderator from Clearnet. I wholeheartedly welcome all the delegates across the country. We are fortunate enough to get supported by the doctors. Thank you to all the doctors for taking the time to join us today. I would like to take a minute to introduce our platform Clearnet. Clearnet is one of the largest live digital CME platforms in India where the doctors can generate their medical content. Now I'm taking this opportunity to welcome today's master doctor, the eminent speaker, Dr. A.G. Jayakrishnan. He has done MS, FRCSI in general surgery, FRCS in cardiothoracic surgery. He is also the chief cardiothoracic surgeon and director at Department of Cardiology at Omega Hospital, Mangalore. He is also the consultant cardiac surgeon at Justice K.S. Hegre Charitable Hospital, Mangalore. Now, without any further delay, I would like to hand over the session to you, sir. Kindly proceed with your talk. Over to you, sir.
okay. Good evening, everyone. And thank you, ClearNet, for arranging this talk from me. It's about minimally invasive cardiac surgery. The topic today is minimally invasive cardiac surgery. Okay. So there are many ways of treating coronary artery disease, which is by giving medicines or medical management of coronary artery disease. This, of course, is the least invasive of all kinds of treatment that you can give for coronary artery disease. But we are talking about minimally invasive heart surgery, not the treatment by medicines. Of course, there are also catheter-based techniques like angioplasty and stenting, etc., which are also considered less invasive than coronary artery bypass surgery. So these are the three main modalities of treatment for coronary artery disease. So I will talk about minimally invasive heart surgery or cardiac surgery. So for many years, right from the initial days when coronary artery or cardiac surgery initially started from 1952 onwards, gradually, heart surgery has always been performed by, it is one of the most common surgical operations performed worldwide. About 5 lakh coronary artery by heart surgeries are performed in the United States every year. And the only other operation which is done in more numbers is probably hip replacement. And nowadays knee replacements are also being done. But basically it's a very commonly done surgical operation. And since a very long ago, the coronary cardiac surgery has been done by stopping the heart, by connecting the heart to a heart-lung machine and stopping it while the surgeon does the surgery, whatever surgery it is, whatever heart surgery it is. It may be congenital heart surgery like closure of heart defects, which are by birth heart defect like hole in the heart, or valve replacement surgery, or coronary artery bypass surgery. All the surgeries has been done by stopping the heart while the surgeon does the operation and connecting it to a heart-lung machine. But this has been a major invasive surgery for two reasons. The heart surgery was always done by opening the cutting the breastbone and exposing the heart in the mediastinum. The sternotomy, or the sternum or the breastbone, is split into two, and that gives easy access to the heart. And that is how for several years it was done. And also the necessity, the heart is always moving, beating continuously, and the surgeon, it was very difficult for the surgeon to operate on a moving heart. So therefore, out of necessity to operate on the heart, it was necessary that the heart be stopped while the surgeon does the heart operation. And the heart can only be stopped by connecting the heart to a heart-lung machine, stopping the heart, and while the heart is stopped, by supplying the blood to the rest of the body through the heart-lung machine, whereby the blood is taken out of the body, oxygenated in the oxygenator, which is part of the heart-lung machine, and then put it back into the blood. So this was absolutely essential to do the heart operation. any heart operation. But what is interesting is that the very first coronary artery bypass was done on the beating heart, that is without stopping the heart. That was in 1962 by Kolesov, a surgeon in Ukraine, which is in the old USSR. And in this, on that surgery, he connected the through a small left anterior thoracotomy, not by a sternotomy, which I explained earlier, but by through a left anterior thoracotomy, small incision, the internal thoracic artery, which is commonly called the internal mammary artery, was connected to the LAD, the left anterior descending artery, on a beating heart. So technically speaking, the very first coronary artery surgery was a minimally invasive surgery performed by Kolesov in 1962. However, this did not gain popularity because of the difficulty involved in this type of surgery. It was only the invention of the heart-lung machine that that there was a huge rise in the number of coronary artery bypass surgeries being performed, which helped the surgeon enormously because the heart could be stopped. Unfortunately, the use of the heart-lung machine has its own complications, and the need to stop the heart also created some complications. So most of the morbidity and mortality of coronary artery bypass is largely attributed to the use of the heart-lung machine, or CPB, which is known as cardiopulmonary bypass, and stopping the heart. You have to inject a solution which is rich in potassium and contains various other chemicals and stop the heart. And the blood supply to the heart is interrupted for as long as you have to do the operation. But on its own, this created some complications, especially in the earlier days. There were more complications, lot of complications from this. There were adverse cerebral outcomes like stroke and temporary memory loss, etc., etc. Many adverse neurological outcomes because of the use of the heart-lung machine itself. Nearly 0.26% of patients had complications due to use of the heart-lung machine. This also included problems like renal dysfunction, lung dysfunction, and many other associated complications because of the use of the heart-lung machine. Another important complication which occurred was the activation of the inflammatory and complement cascade because of the exposure of the blood to the artificial circuit of the heart-lung machine and the oxygenator. The blood had to pass through this circuit, which is made of the heart-lung machine circuit is made of plastic and various other materials. And because the blood was necessarily passing through it to get oxygenated, the inflammatory cascade was activated as well as the complement cascade. This came to be known as the systemic inflammatory response syndrome, or SIRS. This could be in vast majority of patients. This was very mild, leading to mild fever or mild organ dysfunction, which recovered spontaneously. But unfortunately, in a group of patients, this could be very severe, leading to cerebral outcomes, frank pulmonary edema, acute renal failure, etc., etc. And another important complication was hemodilution. Hemodilution was essential because to prime the heart-lung machine, lot of fluid was used, fluid to prime the machine, and the blood was diluted. And again, because of this hemodilution, there was usually a drop in hemoglobin, hematocrit, etc. And in the old days, a lot of donor blood was used in cardiac surgeries. And hypothermia was another important aspect of cardiopulmonary bypass, mainly for safety reasons and as a protection to the myocardium. When the myocardium is stopped by injecting these chemicals like potassium, it was also essential to reduce the temperature of the heart. Well, that could only be achieved by reducing the temperature of the whole body. So hypothermia itself also caused some complications in the whole body system. So all these were part and parcel of heart surgery for a very long time. So because of all this, various surgeons tried to avoid the heart-lung machine over many years. Many techniques were tried. Eventually, so around in the late 90s, the idea of beating heart surgery came into being. But unfortunately, the surgeon had two great obstacles. One was the movement of the heart. The heart is continuous. If the heart is not stopped by artificially and connected to a heart-lung machine, obviously the heart has to work to keep the body perfused. So the beating heart was a big obstacle to the surgeon, especially in coronary artery surgery, when the anastomosis is a very fine anastomosis. We use very fine sutures and to connect the coronary artery, to connect the bypass graft to the coronary artery. And this technique was extremely difficult when the heart is continuously moving. You can very well imagine the difficulty of a fine anastomosis being done on a beating heart. So that was one great obstacle. And another great obstacle was that to do the bypass on the back of the heart. Obviously, the heart, you have to imagine the heart in a 3D view. There are vessels on the front of the heart, which was easier to graft because they are directly in front of you. But to do the bypass on the vessels on the back of the heart, you had to lift the heart. So lifting the heart caused a lot of hemodynamic instability because the heart is upside down, and then you have to do the anastomosis on the beating heart. So the vessels, so the blood pressure in the patient dropped, and it was very difficult to do these cases. So initially, when the beating heart surgery came into being, only the vessels on the front of the heart were done. And those patients who needed bypasses to the vessels on the back of the heart were done on the beating heart. It's only when surgeons got more and more experience and more and more devices came in to help the beating heart surgery to be done a little bit easier, then only the vessels on the back of the heart could be anastomosed during coronary artery surgery. So this is a view of a heart-lung machine. You can see very well, it's a very, very complicated machine. This is the blood passing through the tubings. You have 4 pumps here, one for suction, one for the arterial blood taken from this is the oxygenator will be somewhere here. This is the oxygenator and various other tubing. So it's a very complex machine, and we needed a highly trained perfusionist. Is not a doctor usually, it's a technician who has been trained in this use of the heart-lung machine to operate this machine. And they have to be very well trained so that they are in full control of the perfusion of the body while the patient is connected to the heart-lung machine. So what exactly is minimally invasive coronary surgery? I'm using the term coronary surgery to mean cardiac surgery. Most of the beating heart surgeries are usually coronary artery surgery, what I'm talking about. Other cardiac surgeries can also be done, like closure of defects, valve replacement, etc., are also being done by minimally invasive techniques. So there are various terms which might be a little bit confusing. OPCAP or off-pump coronary artery bypass. This was the very first technique that came into use in minimally invasive heart surgery, which means off-pump coronary artery bypass. Off-pump means without using the heart-lung machine. Heart-lung machine was referred to as the pump because it pumps blood back into the heart. So it was referred to as a pump, but that is what it means is a heart-lung machine. So off-pump means without using the pump. Off-pump coronary artery bypass, this was done usually through a sternotomy. And as I said, because of the movement of the heart, single or occasionally earlier days, multi-vessel coronary artery bypass was done without using the heart-lung machine. So there was no heart-lung machine in use, but it was done through a sternotomy. Then gradually it came that something called mid-cap, which means minimally invasive direct coronary artery bypass. In this case, both the sternotomy and the heart-lung machine were avoided. But again, only the vessels on the front of the heart were anastomosed using this technique. You see the LAD or the diagonal. What we did was through a small thoracotomy, anterior thoracotomy in the left fourth or fifth intercostal space. The left internal thoracic artery or mammary artery was prepared through that and connected to the left anterior descending coronary artery through the small incision on the left side of the chest. Again, heart-lung machine was not used. So this is known as mid-cap. As surgeons got more and more experience, the idea of port access CABG, which is basically endoscopic coronary artery bypass, came into being, whereby in this case, more bypasses could be done using these minimally invasive techniques. But we could not avoid heart-lung machine because vessels on the back of the heart to be anastomosed, we needed to connect the patient to a heart-lung machine, but not through the standard sternotomy, but through a femoral artery cannulation, whereas the femoral artery and femoral vein were cannulated for arterial return and for venous return, and a small incision was used, or endoscopic instruments were used to harvest the mammary artery and sometimes also to connect the coronary artery, which is becoming more and more popular. After some time, the robotics came into the picture. The robots were used to do the anastomosis, which became, of course, the cost of the robot was one very important limiting factor. But then robotic surgery had many advantages, which is that the surgeon's hands are big. So you needed a big incision for the hands to go in. But obviously, robotic hands are very small, and the hand has got 360-degree rotation, the robotic hands. So you could, through a small hole, you could rotate your hands, which the surgeon, his own hands, which was impossible to do, and his hands were a little bigger. So obviously, robotic assisted endoscopic coronary artery or other surgeries became popular. The only limiting factor was the cost of the robot, which was extremely expensive. There are very few centers in India which are doing robotic assisted coronary artery bypass or cardiac surgery. So all these changes came about from visionaries who brought out these changes, thinking how to make things better, how to reduce the invasiveness of coronary artery bypass. Just like one of the statements made by Walton Lillehei, who is a very one of the first cardiac surgeons to do cross circulation and close an atrial septal defect in a baby using the mother as an oxygenator. So he said, some people see things and they always think of making changes, and by dreaming of things that never happened and trying to make those changes and say, why not change? Others don't want to change, they like to do things the same way, but there are some others who don't bother at all. So that was one of his statements, which I found it very an excellent statement, so I first thought I will share it with you. So now, as I said, minimally invasive or beating heart coronary artery surgery, we needed to stop the heart without connecting the patient to the heart-lung machine. One of the biggest things that happened during the early days, we didn't have any device to do this. So we used pharmacological means like injecting drugs to reduce the heart rate. We could not stop the heart completely because the circulation had to be maintained. So we injected drugs like esmolol, which is a short-acting beta blocker, to reduce the heart rate so that at least the movement of the heart is reduced. Again, doing vessels on the back of the heart was a bit of a problem using these methods. There were some other electrophysiological methods were also tried, but did not become popular because they are very complicated and difficult to use. Electronic methods like virtual imaging and of course robotics came into being later. But the most important thing which helped beating heart coronary artery bypass surgery is the invention or the discovery of the mechanical stabilizer, basically called the octopus now, which is now widely in use, and that helped the surgeon immensely to perform this beating heart coronary artery bypass. So again, the definition op cap, open coronary artery bypass, it is usually done through a sternotomy and single or multi-vessel coronary artery bypass, but no heart-lung machine. Mid cap, a small thoracotomy, usually single vessel, again no heart-lung machine, no cardiopulmonary bypass. Port access coronary artery bypass, which is endoscopic. So there we use femoral bypass, cardioplegic, sometimes arrest of the heart, but limited and multiple incisions with or without robotic surgery, robotic assistance. And then, of course, we have the completely robot-assisted cardiac surgery. This was the invention or discovery that I told you about, which is called an octopus tissue stabilizer. What this basically does is, these are two suction pods, and they have suction cups, 1, 2, 3, 4, 5 cups on either side. And this is connected to a wall suction. So when you apply suction, this grips the heart on either side. This is the left anterior descending coronary artery. So it grips the heart on the side, on both sides of the coronary artery, and stabilizes that area only. So that area becomes virtually standstill. It is not completely standstill, but almost standstill, while the rest of the heart is moving normally. So only this little around 1 inch area is reduced almost standstill. It doesn't affect the performance of the heart. The blood pressure is maintained normally, and the lungs are working normally. There is no need to use a heart lung machine. Using this device, and another device also came into being, which is called the starfish heart positioner. This was device which is used to, again, same principle, the suction tube, which is connected to a wall suction. And here this you apply to the apex of the heart, so that this device grips the apex of the heart, and using that you can move the heart in any direction and position it. This is a highly flexible arm. It's an arm of the device. And if you tighten this, the arm becomes rigid. So initially the arm is very flexible. Once you grip the heart and keep it in the position that you want, you tighten this you just turn this knob and tighten it, and it will stay in that position. So this helps to position the heart in various ways while it is working normally. So the surgeon need not physically touch the heart. You can grip the apex of the heart and keep moving it in any direction you want, and then use the octopus where you want to do the anastomosis. So these two devices, that is the starfish, and the octopus and the starfish stabilizer, help dramatically to increase the use of beating heart coronary artery bypass surgery. There are, of course, this is one company. There are slight modifications which are also is available in the market, made by various companies. They are a little expensive, but then you can avoid the heart lung machine, the oxygenator, etc. So cost saving also is considerable. And because of the avoidance of the heart lung machine, the complications associated with the use of heart lung machine is also avoided. This is the minimally invasive direct coronary artery bypass. LAST means left anterior small thoracotomy. So instead of a sternotomy, which involved splitting the sternum in the midline, we go through a small opening in the left side of the chest in the 4th or 5th intercostal space. Again, the octopus device is used during the surgery. The thoracotomy is spread, and this is the left anterior. This is the coronary artery bypass being performed through a left anterior small thoracotomy. It is the octopus device is used on either side of the coronary vessel to stabilize it, and the mammary artery is being. You can see that this is the mammary artery, which is being harvested through the same incision. So very often nowadays, of course, we use endoscopy to harvest the mammary artery and then do a direct coronary artery. It is called direct because it is done by the surgeon directly looking at the heart and using his hands to construct the anastomosis. In this type of surgery, there is no robotic assistance used. But the whole thing, when done with robotic assistance, the opening can become even much smaller, because the robotic hands are very small, and you can use the robot to help you do this surgery. So robotic cardiac surgery is heart surgery done through a very small incision in chest. It is not one incision. It will be multiple small incisions. With the use of tiny instruments and robot controlled tools, surgeons are able to do heart surgery in a way that is much less invasive than conventional open heart surgery. Only thing is, this is a typical scenario of a robotic assisted cardiac surgery or coronary surgery. The surgeon is not anywhere near the patient. Here is the patient. There needs to be a nurse or an assistant to position the robotic arms. There are multiple robotic arms. There is a camera, there is a console from which you can see the view of the heart, and multiple arms. The camera and the robotic arms have to be introduced into the chest through multiple small incisions. So surgeon need not even be in the operating room. And theoretically, surgeon can be anywhere. He could be anywhere in the world and still control the robot by electronic means and do the surgery. Of course, one surgeon at least has to be in the room to convert, in case of difficulty or small accidents, to convert it into conventional surgery. It will be very unsafe not to have any surgeon in the premises, but theoretically it is possible. Again, as I said, to do robotic heart surgery, you need multiple small incisions, mostly about 1 inch or so. So in this particular case, you have 1, 2, 3, 4 incisions, one for the camera, one for the forceps, one for the various instruments have to be introduced, one for the stabilizer. So it is multiple small incisions, which are, there is no rib cutting, there is no sternal splitting, and it can be done with or without CPB, but with these small incisions, very often cardiopulmonary bypass may be required. So with the introduction of minimally invasive techniques into cardiac surgery, what was once a formidable operation has been converted into a simple and easily reproducible surgery. The benefits to the patients of minimally invasive cardiac surgery are enormous in terms of early recovery and return to work, less pain, less blood use, and less systemic complications. So thank you very much for listening to me. If there are any questions, I can answer them. Thank you.
All right. Thank you so much, sir, for the overall comprehensive talk. The presentation was so informative and the lucid explanations. Moving on, sir, we have received few questions from the participating doctors. With all your permissions,
Yes.
can I put them across?
Yeah, sure.
Sir, may I stop the presentation from my
Yeah,
end?
yes, you can do that.
All right, sir. Moving on, so the first question we have received, what are the key advantages of MICS compared to traditional open heart surgery in terms of patient outcomes, recovery time, and complications? So Dr. Venkat Rao has asked this.
Patient outcome in experienced hands is exactly the same, because that is the whole idea of minimally invasive cardiac surgery. One of the main advantages is the small incision. Stenotomy, which means cutting the breastbone, splitting it in the middle. Sometimes, of course, it's a very safe incision, and healing can be a problem. Sometimes the bone may not join together, or in case you get an infection, then it becomes a chronic problem. So this is one of the advantages of minimally invasive is the small incisions, 1 inch or so, maybe 3 or 4 or 5, but they heal very fast because no bone is cut. The second most important advantage is because of the avoidance of heart-lung machine. The non-cardiac complications are almost nil. Almost nil. Of course, you can never have zero complications, but the non-cardiac complications like stroke, renal failure, and the problems of lung complications, lung infections, all that is much lower. So patient recovery is much faster, very much faster. A minimally invasive cardiac surgery recovery is almost like a general surgery operation. Heart-lung machine is not used at all. And then the use of blood in the blood loss is very minimal in minimally invasive cardiac surgery. So the use of blood, donor blood, is very much less in minimally invasive surgery. These are the main advantages. Recovery is much faster.
All right, sir. Moving on to the next question. What type of incisions are typically used in MICS and how do they contribute to reduced trauma and faster recovery?
Yes. So again, as I said in the talk, the usually standard coronary artery bypass is done by splitting the sternum or the breastbone. You divide the sternum, and then you have to, at the end of the operation, you have to reunite the cut ends by using stainless steel wires. So this is like a fracture. You are creating a fracture of the sternum. So it will take 6 weeks to heal for the sternum to join together and become solid. Of course, the union can be delayed. There can be infections which may lead to even sternal osteomyelitis. And these are some of the main complications of the sternum. In minimally invasive surgery, this is completely avoided. There is no bone that is cut. It is only the incisions are all through the intercostal space. We have to remember that avoiding even rib cutting is very important. So it is only through the intercostal space you may make 4 or 5 incisions. So the healing is much faster. This is the main advantage, in one of the main advantages. Secondly, of course, is cosmetic, especially in ladies. If you have a big scar in the midline, it is not very appealing cosmetically. And in some patients, they can form some keloids Even though the bone has healed, the skin incision may look sometimes very ugly, forming keloids. But if you use a thoracotomy, the incision is not in the middle. It is not obviously apparent. It can be concealed by garments, whatever garments. So it is very cosmetically more appealing. In fact, that is one of the main advantages of avoiding a stenotomy in females, young females. So these are the two main advantages of minimally invasive coronary artery by cardiac surgery.
All right, sir. Moving on to the next question. How is patient selection determined for minimally invasive cardiac surgery, and what factors contribute to the decision-making process? Dr. Datta has asked this.
Yes, thank you. That's again a very important question. See, when we started doing minimally invasive surgery, we were highly selective. We only selected patients with one of the most important indications were good left ventricular function, because during the surgery, patient can develop problems with the myocardial contractility. So we may have to go to connect the patient to a heart-lung machine as an emergency, which is extremely difficult when you are doing it through a small incision. So we do a stenotomy, then it becomes much easier. You can cannulate the aorta, you can cannulate the atrium and go on bypass in a hurry. So patients with poor left ventricular function were not usually selected for minimally invasive surgery. But now with more, it has been going on now almost 20 years. Surgeons have become more and more experienced, and there are many, like I showed you, many devices are available. And therefore, the experience of the surgeon and the refined equipment available has helped us to extend the benefit of minimally invasive surgery to more and more patients, to poor risk patients, older patients, etc., etc. So it's therefore mainly the advances in instrumentation and cardiac support that has helped us to move away from even doing high risk patients through minimally invasive techniques.
All right, sir. Thank you so much, sir, for answering all the queries of the doctors, and thank you to all the participating doctors for your continuous participation at our platform. Thank you once again, sir, for your valuable time and for being with us and for sharing such valuable insights. So, with all your permissions, can we conclude the session over here, sir?
Yes, thank you.
Yeah. Thank you so much, sir. Take care. Thank you.